come over here is a pretty nice thing for you guys. We're going to be, let's go through. So obviously this is what we're going to be covering. The main topics that we're going to go through today is hypertension, valvular diseases, rheumatic fever, infective endocarditis, and HOCM. Just to let you know, as an if you are at the end, if there's anything that's confusing you, etc., pop it in the chat, and we'll do our best to be able to answer that question there and then. And also, if you have any, I know that there's going to be a wide variety of people here, perhaps from people who've just started clinical medicine to those who are coming up to almost starting F1. And I personally, a lot of help when I was going through this entire process. I understand that it's tough, it's scary. But I'm really happy to stay behind, and we can have a bit of a natter after, just to give a little bit of advice if it's useful. And I'm sure Nisarg and other people in this group can actually help with that as well. So also to get excited and talk a little bit quickly sometimes. If that is the case, please just go ahead, slow me down, just say, Rohan, that's a bit quick. Can you slow down a little bit? Mirrors, I think your mic is on. It's off now. Fantastic. Without any further ado, let's get started. So we'll start off with some SBAs. There's an 83-year-old gentleman who's come into the GTS for the results of his ambulatory blood pressure readings. The average BP is 145/87. He's got no other presenting, and his past medical history is for an appendectomy when he was 14. Based on the above information, what is the best management of this patient's hypertension? A, amlodipine, B, bisoprolol, oh, well done, C, candesartan, ramipril, or E, monitoring. So I will give you a few seconds to be able to just answer those questions for me, and we'll see what we come up with. So let's give you about 30 seconds from now.
Sorry for pointing that up earlier. Didn't realize it would go on so soon.
All good, mate. It's really exciting watching this go. Okay. Well, there is a bit of feedback. I think Akash, you might, right. So you might want to switch that off if that's okay. Thank you. Cheers. Okay, cool. So that is 1 minute. And so the majority of us has gone for E, and there's a few for A. So the correct answer for this patient is E. So basically, go over how we manage hypertension and the algorithms that we use for that a little bit later on. But effectively for this patient, the answer is monitoring them. The reason why is because they're 83. We'll find out later that a threshold is above 80, with an average BP, which is just a little bit hypertensive, is otherwise got no other problems. So basically the logic is that as they're a bit older, give hypertensive, antihypertensive, sorry, is going to be cause them a bit more harm than it would do them good for this sort of blood pressure. And accordingly, we just monitor this patient. Amlodipine and bisoprolol, candesartan and ramipril, they're all different lines that we could use if we're going to be treating this patient, but obviously we're not going to be doing it in this particular scenario. And I'll go into it a little bit further on as well, and go into the actual the algorithms a little bit further on. So let's go over hypertension. So first of all, what does it mean? So hypertension means high blood pressure. It's defined as a clinic BP of above 140/90 or an ambulatory blood pressure of above 135/85. In terms of what causes it or etiology, it can be idiopathic, so don't know, just something. It can be an endocrine cause. So there's these things called chromocytes. These are tumors of the adrenal glands, and they release catecholamines, and you can remember adrenaline, that sort of thing, but releasing them into the blood system, and that's causing your blood pressure to rise up. Cushing syndrome, which is a increased production of cortisol, can also increase your stress response, and therefore also your the risk of you getting high blood pressure. There's also the renal system as well, so renal artery stenosis. So stenosis of the arteries going towards the kidneys, that causes effectively an increase in the RAS system, so renin-angiotensin, aldosterone-angiotensin system, which acts to increase your blood pressure. Just as a sort of aside, by the way, something that does come up in SBAs quite a lot is a patient who's got They're absolutely fine. Generally, they're a little bit older. Usually, you've started them on an ACE inhibitor, and their EGFR absolutely plummets. The reason why, they ask you what's the reason why, and it's actually one of the things that could be is renal artery stenosis. I can go into the pathophysiology a little bit later if people are interested, but it's because of this. If someone's got bilateral renal artery stenosis, ACE inhibitors are contraindicated. So that's just a sort of SBA little point that you might want to know or show off a little bit with on the wards if you need to. Obviously, if someone's in pain or if they're emotionally stressed, your blood pressure gets a little bit higher. We can all relate to that, I'm sure. Clinical features. So often it's actually an incidental finding and there's not anything specific going on, but you can have headaches, visual disturbance, and further on kidney injury and heart failure associated with high blood pressure as well. All right, so that's just a few of the things on high. Then the next thing is, how do we actually go about diagnosing that? I'm sure that you guys are all medical students, so you're very familiar with this lovely website called pastmedicine.com, which covers it really, really well. I would use that as one of your premier revision resources. What we would do, if we're one of the GPs, we would be taking a look at the clinic blood pressure. If it's above 140/90, we're like, that's a bit high. But is this something that's just happening here in the clinic, or at home as well? So it'd be offering them ambulatory blood pressure or home blood pressure monitoring. That's basically they're taking this blood pressure consistently over a period of a few days to just see what the average is when they're at home. If the average is fairly low, then they're not hypertensive, so screw it, doesn't matter. Just monitor them, all good, that's fine. If the blood pressure is fairly high, above 150/95, then any patient, regardless of age or anything else going on, will start it on treatment for their hypertension. Okay. If it's between these two values, then we start thinking about it a little bit more, and they have to meet certain criteria. So if they're below 80 years old and they've got any of the following things: target organ damage, established cardiovascular disease, renal disease, diabetes, or a 10-year cardiovascular risk equivalent to 10% or greater. What does that mean in English? That means that you use your Q risk score, which is an online calculator. You type in the patient's details, it pumps out a number. And if that number is above 10%, which means 10% risk of this patient dying from a cardiovascular cause in the next 10 years, then you would start them on treatment. I was also, remember when I was a med student, I was always heard this term end organ damage being thrown around, didn't really know what it means, but it's just the organs right at the end of the system that could be damaged by the high blood pressure. So one of the things is the heart. So they could have ischemic ECG changes which are happening in the heart because it's just struggling to pump that blood around and it's getting a bit tired and lethargic and it's becoming ischemic because of that. The renal system can be affected. So if you can just imagine a lot of pressure on that kidney or lack of pressure even on that kidney, then that's going to reduce the amount of blood flow to the kidney or increase the amount of blood flow to the kidney, and that can lead to kidney damage. So you'd be thinking about things like a urine albumin creatinine ratio and also checking the user needs as well to see if there's any proteinuria or if this patient's developed an AKI or chronic kidney disease secondary to their high blood pressure. And also, very importantly, you want to be checking the eyes as well. So we're looking for signs of papilledema or retinal hemorrhage. And you can just imagine that if that blood pressure is really high, you've just caused bursting of those of the arteries and blood vessels which are in the eye, causing these hemorrhages to occur. An interesting thing is, if you have a clinic blood pressure above 180/120, you're a little bit worried by this, understandably, and you decide not. This is what you, being a GP, would be deciding whether or not this patient needs to come into the hospital for a specialist review. And the indications for that would be if this patient's got any problems with their eyes, so the papilledema, retinal hemorrhage that we talked about before, or there's anything else that's life-threatening that you would be concerned about, such as heart failure, AKI, a chest pain indicating that this is proper ischemia, or a new onset confusion, or if you're thinking about a pheochromocytoma, so palpitations, headaches, and abdominal pain, the symptoms that you can get with that. If you don't have any of these things and you just want to be investigating that end organ damage, so if, by doing all of this stuff, ECG, albumin creatinine ratio, taking some blood tests, if it is present, then you would, after you've not sent them home, you're going to be assessing exactly what's happening and send them home with ambulatory blood pressure monitoring, along with the other investigations to be done within the next 1 or 2 days. If you find one of these issues, you would be offering drug treatment immediately before waiting for the ambulatory blood pressure readings to come back. If they're not present, then what NICE said is to repeat the blood pressure within 7 days. So that is in terms of hypertension diagnosis. Are there any questions at this point that people are a little bit confused about? Okay, cool. I'm going to assume that's a no, and I'm going to move on. All right, if there is anything that comes up, just go ahead. So second SBA then, 73-year-old Caucasian gentleman comes into the GP practice with the results of his ambulatory blood pressure monitoring. Average blood pressure at home is 170 over 105, and his past medical history includes hypercholesterolemia and type 2 diabetes. He has no known drug allergies. What is the most appropriate management of this patient's hypertension? Ramipril, candesartan, bisoprolol, amlodipine, or verapamil? Oh, well done.
Well, the timing right this time, I think.
Okay, that's coming up, and I'm smashing it, mate. I'll give it about 10 more seconds. Right, I'm going to end this poll, see what that does. Fine. Do I click? Oh, fantastic. Good man. Right, sweet. So a lot of people have gone for A. People have gone for B. D seems to be a popular option, and E as well. Well done. The majority of you have that correct. It is A, ramipril. If you haven't got the correct, absolutely fine. That's the reason you're here in this place. Well, giving it a go. So in this patient, the main thing, first of all, when you approach a situation, always look at the demographics, because that's always important for some reason or another. In this case, it's a bit of a red herring. This guy has come in, he's had the GP practice, he's had ambulatory blood pressure monitoring, and his blood pressure at home is still high. His past medical history includes and type 2 diabetes mellitus. The important learning point from this question is that if a patient's got type 2 diabetes, then the first hypertensive agent that they start is ramipril, which is why ramipril is the correct answer. Candesartan is a ARB, which you would start if the ACE inhibitor isn't tolerated. Bisoprolol is a little bit further down the line. Amlodipine is a calcium channel blocker, which you would start if they don't have type 2 diabetes, they're above 55, or they're Afro-Caribbean. And verapamil is a cardioselective calcium channel blocker, which you don't really use for managing hypertension. Just as a sort of note, a really good way of remembering how to differentiate these two types of blockers. So you've got your calcium channel blockers, you've got the ones that act on the heart and the ones that act peripherally. The ones that act on the heart are verapamil and diltiazem, right? And you may or may not know that there's a dating app for the South Asian community called Dilmil. So diltiazem and verapamil are for the heart, whereas peripherally acting agents are your penes, your dihydropyridines, right? So you've got your amlodipine or phenolidine are peripherally acting agents, and that's what you use for blood pressure. So that's just a quick. Would we still give amlodipine if the patient didn't have diabetes? We'll find out on the next slides, okay? So if they're above 55, let's just go. So you would go for amlodipine first line, if that was the case, yeah. Perfect. Any further questions? That one. All right, sweet. Right question then. 58-year-old Afro-Caribbean gentleman comes into the GP practice as his blood pressure is still not appropriately controlled. He has a past medical history of asthma and is currently on ramipril, indapamide, amlodipine, and a rescue salbutamol inhaler. His ambulatory blood pressure is 143 over 90, and his reasons are shown below. What is the next most appropriate step in this patient's management? Losartan, bisoprolol, doxazocin, spironolactone, or bendraflumethiazide? And we'll give you a few minutes, give you about 30, 45 seconds, I reckon, to try and get an answer to that.
Remember, guys, the polls are all anonymous, so you guys can answer without being afraid.
Absolutely. Five seconds is my sort of limit, I reckon. Cool. So I just click end poll, right? Cool. End poll and share results. Right. So the majority of us have gone for A, the answer, and then there's B, C, E, and E. So let's look at what the correct answer is for this patient. Okay, so let's just draw your attention to a few things here. First of all, 58-year-old Afro-Caribbean gentleman. Okay, fine. Comes into the GP practice and is not well controlled. He's got a past medical history of asthma. That's really important. And is currently on ramipril, indapamide, amlodipine, and a salbutamol inhaler, but his blood pressure is still not controlled. Because of this, we need to go to a fourth-line therapy. And the answer here is actually C, doxazosin. Can't remember how many people got that. So let's go through it together. So as we'll go through on the next slide, we'll go through the management of the management levels of high blood pressure. Oh, thanks, mate. The management levels of high blood pressure and what we use first and second and third and all of that stuff. Basically, this patient's had the three-line therapies that we'd use as the had the first three steps of the therapies that we would use, which would be an ACE inhibitor, a thiazide-like diuretic, and a calcium channel blocker. Because of that, the next step is to look at the patient's potassium. If the potassium is less than 4.5, then we can safely give a potassium-sparing diuretic like spironolactone. If it's above 4.5, then we go for an alpha blocker or we go for a beta blocker. And the decision is really made as to what's probably the cheapest, but also what other comorbidities does this patient have. So in this patient, we know that they've got asthma, and in asthmatics, beta blockers are contraindicated. Now, the reason why that occurs is that, remember what a beta blocker is, it's blocking beta receptors. And remember, the main medication that we use to treat asthma, or one of them, especially for rescue, is salbutamol, which is a beta-2 agonist, right? So if you blocked those beta-2 receptors, stop your salbutamol, and you can also risk bronchospasm. Therefore, beforehand, you were left with a choice of alpha blocker or beta blocker. You've no longer got beta blocker as an option. Therefore, you've got to go for your alpha blocker, which is why C is the correct answer. Let's go through the other options as well. So this patient's already on an ACE inhibitor, and losartan is an ARB. So we would use an ACE inhibitor. So we would use losartan if they're not tolerating the ACE inhibitor, usually because of consistent cough, and I can explore the pharmacology with you later as well if you need to. But basically, you don't give an ACE inhibitor and an ARB at the same time. We've talked about bisoprolol being a beta blocker and why we wouldn't use it in an asthmatic. Spironolactone, so if the potassium was less than 4.5, then we would go for Spiro. In this case, it's 4.7, so we wouldn't go for Spiro, because if we gave potassium, we gave the potassium channel blocking, if we gave the potassium sparing diuretic, there's a risk that potassium would go higher than we needed to go. And the bendraflumethiazide, we've already got a thiazide-like diuretic in place here with indapamide, so we wouldn't need to go and repeat that again. So I hope everyone's happy with that. If you do have any questions, pop them in the chat, and if you just let me know what's going on. So in terms of management of high blood pressure, first of all, standard stuff, lifestyle changes, don't eat so much salt, lose some weight, go for a run, do all of that stuff. And then after that, working through this algorithm. This is again, it's taken from past med. Sick, use it. And we'll go with, so if they're below 55 years old or they're type 2 diabetic and also not Afro-Caribbean, then we would start off with A, which is an ACE inhibitor and angiotensin 2 receptor blocker. So the ramipril, enalapril stuff, losartan, all of that kind of sartan stuff. All right, that would be our A. If they're above 55 years old and no type 2 diabetes, or they're from the Afro-Caribbean community, then you would start off by going with C, which is your calcium channel blockers. And remember, this is the peripherally acting calcium channel blockers, so your PEEMs are the ones. So amlodipine, felodipine. If after this stage you it's still not controlled, then you would then add on either the calcium blocker or a thiazide-like diuretic. if you've started off on an ACE inhibitor, or you would add on a ACE inhibitor or a thiazide-like diuretic if you just started off with a calcium channel blocker. And then step 3 is 3 drugs. And then step 4 is, as we've discussed before. So if the potassium is less than 4.5, add Spiro. If it's above 4.5, add an alpha blocker or a beta blocker. If it's still not controlled, then after that would be referring up either to the nephrologist or the cardiologist to be able to look at that a little bit further. What if they're type 2 diabetic, plus 55, and Black Afro-Caribbean? In that case, if they're above 55, type 2 diabetic, and Afro-Caribbean. So in my opinion, what I understand it to be, obviously, if you want to check it out and make sure that's not correct, then I think because the renoprotective effects of the ACE inhibitors in type 2 diabetics is so much, my understanding is that you would go and give them ACE inhibitors. That's my understanding of it. And so if you want to check that and fact check me, absolutely perfect. But that is my understanding, is that you would go for the ACE inhibitors as being the first line of that population. I hope that helps. Any other questions regarding that point? Cool, let's move on. So hypertensive. So this is just thinking that can go wrong with high blood pressure and why it's important that we need to control it. So cardiac, I like splitting it up into systems. So cardiac causes, cardiac problems, cardiac hypertrophy, myocardial infarction, heart failure, aortic dissection, all got increased risk if you are hypertensive. You've also got an increased risk of stroke, TIAs, vascular dementia, retinopathy, and you've also got an increased risk of kidney diseases. I found a mnemonic because med students love mnemonics, as do doctors. So the 4 C's you can remember for hypertension is your coronary artery disease, congestive heart failure, chronic renal failure, or cerebrovascular accidents as well. So strokes. So that is that for hypertension. Hello. Yeah, I'm pretty certain. Just because of the renoprotective effects are so good for ACE inhibitors, they really like them in diabetics. The reason why that they don't use them in Afro-Caribbean populations, usually they've got a reduced amount of ACE just as a background. But from what I remember having asked a similar question back in when I was a med student, is that despite this, we still go for the ACE inhibitors in either population when they've got diabetes, because it's just that good in diabetes. And I think the evidence base is just that strong in that population as well, which is why we go for evidence-based medicine, of course. So let's go next one. SBA4, a 62-year-old man comes in for a review. Recently, he has several episodes of CP. He reports feeling groggy for only a few seconds after the episodes and felt slightly breathless with occasional chest pain. On examination, pulse is 90, regular, blood pressure for 110/86, lungs are clear, and there's a systolic murmur, loudest in the aortic region, which radiates to the carotid area. What is the likely cause of his symptoms? Aortic stenosis, mitral regurgitation, aortic sclerosis, paroxysmal atrial fibrillation, or aortic regurgitation? I'll give you a minute to be able to answer this question. Straight in. I did say I'd give everyone a minute, and we've got 15 more people who could maybe have a guess.
It hasn't got nothing to lose, even if you do get it wrong. No one will know who it is.
Yeah, it's worth going for. Yeah, it's worth going for it. And the evidence actually does say that if you do give it a try, you're probably going to, you get more out of the session, but everyone keeps themselves to themselves. So that is a minute. So the results are as follows. So majority of people have gone for A, and I would also for A. So this gentleman's coming. He's slightly older, first of all, excuse me, and he's had several episodes of syncope or fainting. He's recovering fairly quickly after, and he's got breathlessness and occasional chest pain. This is the fact that he's recovering fairly quickly means that this is this to me anyway, sounds a lot more like a non-neurological or epileptic cause, because usually if you've had a fall secondary to epilepsy, you're usually feeling pretty rubbish for a while after, whereas in this patient, we're getting, just obviously this isn't relevant to this question, but just when you're thinking of your blackout questions, etc., or your histories, that can be something to think about, right? He's feeling slightly breathless with occasional chest pain. Okay, fine. He's got blood pressure of 186, so it's not wide. Systolic murmur, loudest in the aortic regions, which radiates to the carotids. I'll just let you know, if it's a systolic murmur in the aortic region and it radiates to the carotids, that is aortic stenosis. Whereas if it does not radiate to the carotids, then it is aortic sclerosis. How you actually tell that upon on auscultation. If you're able to really do that, then fantastic for you. I still struggle, so don't worry if you're in that position, but just letting you know. So mitral regurgitation, that's a pantostolic murmur taking place predominantly in the mitral region that radiates over to the axilla. Paroxysmal atrial fibrillation could definitely be a cause of syncope, but classically the symptoms describes of palpitations. You might be expecting an irregular pulse. Well, this pulse has been described as regular. Apologies, skipped a slide. And there's no murmur necessarily associated with it. And if we've described a murmur in the question, there's a reason we put it in there. It's because we want to pick up on it usually. And that's the reason why. Aortic regurgitation is a diastolic murmur, and it's associated with a wide pulse pressure and multiple eponymous signs as well. So let's talk about valve disease and murmurs. In my opinion, I feel like valvular diseases, I can understand why they can be a little bit tricky if you're trying to memorize them as a list of things. But for me, what really helped is to try and understand the mechanisms of what's actually happening. So if you understand the blood flow through the heart and at what points the valves are going to be shutting and opening, depending upon systole and diastole, you can kind of get a little bit more of an idea of exactly what the murmur is going to be at a particular point. There's really two types, mainly, of that you can have with valves. They're either stenosed, which means a bit of turbulence on opening the valve, or they can regurgitate, which means that they are just a bit leaky and they let stuff through when it's not meant to be there, right? In real life, for me, because I'm aware, for me, and I'm sure for all of you guys as well, because I have a decent idea in my head of what the systolic murmurs would be and what systolic murmurs would be, I just go, okay, it's loudest in this region and it's systolic, therefore it has to be this murmur, or it's diastolic and in this region, so therefore it has to be that murmur. So let's go through what that means. The systolic murmurs on the left side of the heart, most common ones, which is why they've been highlighted here. That's your aortic stenosis and mitral regurgitation. Remember, and then your pulmonary stenosis and your tricuspid regurgitation for the right side of the heart, right? And again, if you're in systole, ventricles are contracting, the blood's trying to push its way through the aortic valve and the pulmonary valve. So if they're a bit rubbish, then it's this, the murmur would be because they're struggling to open. So therefore the murmur would be of the stenosis of those valves. Whereas if it's of the tricuspid or the mitral valves, then if there's a murmur there, these valves should be closing in systole, and therefore if there's a murmur there, it's likely because the valves are leaky or something. So that's the regurgitation aspect. Exact opposite for the diastolic murmurs. So the left side, most famous one is the aortic regurgitation. The other one that you can think about, may expect as well, is mitral stenosis. And the right side of the valve, you've got regurgitation and tricuspid stenosis. A mnemonic that so I'm sure that doing your cardio exams, or if you've not covered cardio exams yet, one of the things that you're asked to do is to be able to exacerbate a particular murmur, and you ask that by pushing the patient in different positions and asking them to breathe in and breathe out. So a mnemonic, the right-sided murmurs get louder on inspiration, the left-sided murmurs get louder on expiration. So the mnemonic there is RILE, I-L-E. Metal valve sound really clunky, so when you're doing your examinations, that's what you'll be looking for. And if you're stuck, rheumatic fever and infective endocarditis can cause any murmur. All right, and these are the different regions of the heart. I see a question. The attack lasts a few seconds. The aortic stenosis doesn't disappear. So basically, like, what's happening is that the patient's trying to exert themselves a little bit for whatever reason. So at the baseline, that valve, the the cardiac output of that valve is sufficient to be, the cardiac output of that heart, or the amount of blood coming out of that heart is sufficient to be able to provide the blood supply to the brain and everything else that we're going to do, and it's absolutely fine. When the patient's trying to move about, or they've just got up or something, then you're going to have a change in where that blood volume is going. So maybe it's going down to the legs, or they're trying to move around a little bit quicker and the blood's trying to go to the muscles, and therefore there's less blood which is going over to the brain. And because of that, now that cardiac output isn't sufficient to be able to reach the brain, and therefore they've got a syncopal episode. And does that answer your question? You're very, very welcome. Anything else? I will take that as a no. So this is a little cheat sheet for common valvular issues. I will talk through it, but if you want me to hurry up and just move through the entire thing, then just pop me a message. So aortic stenosis, the murmur that we talked about, ejection systolic, loudest in the aortic region, radiating the carotid, so what we just discussed. The majority of the reasons why you get that is because you're just old, and when you get old, your stuff calcifies, it's your arteries. To everybody, unfortunately, and that's just becoming stenosed and calcified, and that's the reason why you're getting this problem. If you're a little bit younger, so say that you're in your 30s, your 40s, and you start developing this murmur, then it could be because there's a problem with that valve in the first place. So patients who've got bicuspid heart valves, that valve, if you think about it, is going through more trauma than a tricuspid valve would be going through, right? So accordingly, that valve is going to be that valve is going to be more likely to get stenosed more earlier than the tricuspid one would, and accordingly, these patients may get aortic stenosis at an earlier age. There's also a note, there's a characteristic pulse apparently called the low rising pulse. No idea what that means in real life. An SBA thing, be aware of it. Aortic is really similar, but no radiation to the carotids. Mitral valve prolapse. So this is when the mitral valve in systole is going boop and then opening. It's going boop and then opening, right? So that whoop that you're hearing is that mid-systolic click. So it's going boop, boop, and that's the classic auscultation of a mitral valve prolapse. Fairly common, and it's also associated with connective tissue diseases. That makes sense, because if that valve is a little bit floppy, then it's going to prolapse easier and go open a little bit easier as well. It can also lead to regurgitation. Mitral regurgitation is a pansystolic blowing murmur, loudest in the mitral region and radiating over to the axilla. It's associated with prolapse, papillary muscle rupture, and heart dilatation. Papillary muscle rupture. So if so that could be coming up in an SBA, like this patient's had a heart attack. Now you listen and you've got a murmur which is going on. What's the MR because of this? All right, that's a particularly that's maybe an SBA thingy. And heart dilatation. So if you've got hypertrophy or whatever it may be, then you may have that ventricle becoming bigger and bigger and bigger, and therefore all the leaflets of that valve is coming out and out and out, and therefore you've got regurgitation happening because of that. You may see stuff on a chest x-ray, such as cardiomegaly, because of the atrial enlargement. The reason why that's happening is because as the ventricle is trying to pump blood into the aortic valve, and that way it's actually going through the mitral valve and expanding the left ventricle a little bit more, and that might be picked up on a chest x-ray. And that ECG can show that classic M-shaped bifid P wave or P mitrale on the ECG, which I'm sure your ECG lecturers have covered previously as well. The aortic regurgitation is an early diastole, which is heard loudest in which is the connective tissue diseases. Also has got a classic collapsing pulse finding, which you pick up on when you do that whole raising the patient's arm when you're doing a full cardiovascular examination. A wide pulse pressure is classically described above 60 millimeters of mercury. That's the difference between the systolic and the diastolic reading. You also got the dancing carotids and the head bobbing demusset sign. I've got silly ways of remembering stuff. If this works for you, then fantastic. A demusset kind of sounds like dubstep to me, and from my understanding of dubstep music, they just go like this and they bob their head. So that's the way that I remembered that one. A mitral stenosis, a mid to late diastolic murmur with an opening snap. They also, in this particular murmur, is associated with a bit of a malar flush, because you've got reduced amount of blood flow through the entire system, basically, and a bit of a backup. So a clog up really of the CO2, which is building up in the body. That can lead to vasodilatation, and especially prominent in the face, there's classic mitral malar faces associated with mitral stenosis. So that's just something to be aware of as well. From an SBA point of view. So management-wise, it's an echo for diagnosis, and really simply, this is not absolutely perfect, but as a good, I know there's people who maybe haven't seen this stuff before, so as a sort of good overall overview, if the patient's asymptomatic, then you don't really go in there and try and, be a hero with them. You just monitor them and see how they do. And we only really go in there if the patient's actually symptomatic, and actually that's when we perform surgery. We've got various different options for the surgery types that we'd actually do. Metallic valve, biological valves are the main valve replacement things that we can do. And we make the choice between which one we're going to do based upon how old the patient is and how long we think they've got to live. If they're fairly young, then we're probably going to go more likely to go for a metallic valve because these are much more longer lasting. Whereas the biological or the pig valves or bovine valves, they are more likely to calcify. The issue with the metallic valves, though, is that they require lifelong anticoagulation because of the shearing forces surrounding the when the blood flow is flowing past the metallic valve, and that increases your thrombotic risk effectively. So they do require they do require anticoagulation to cover them. So that's kind of the disadvantage of those. With the biological valve, they calcify fairly easily. So if the patient's older, then that's probably going to be all right because they're not going to make it for that long anyway. But obviously, if they're a little bit younger, we'd go for the metallic valve. If they're pretty rubbish and they can't sustain a full valve replacement surgery, then we may consider a balloon valvuloplasty for stenosis. I just go in there, blow up a balloon to be able to help shake off some of the calcifications that may be on the valve, for example. Obviously, the risk of that is to turn a stenosis into a regurgitation. So it depends upon the patient and how bad they are. Obviously, we need to treat any complications that may arise from the valvular disease, like heart failure and arrhythmia or whatever else may be going on. Is that fairly clear? Cool, I'm going to assume that's all right. So then, next one, SBA 5. 13-year-old Bangladeshi girl is brought into A&E profusely unwell. Her father tells you she had a sore throat 3 weeks ago and yesterday complained of joint pain in her arms and legs. You notice there is a widespread rash on her skin and she appears to be making these strange rhythmic movements as you approach the bed. She is currently pyrexia and on an ECG shows a first-degree heart block. She has no known drug allergies. Given the most likely diagnosis, which of the following is the most appropriate treatment option? IV chlorphenamine, IV erythromycin, IV flucloxacillin, PO doxycycline, or IV benzyl penicillin. Thank you very much. Okay, sweet. That's 1 minute. So I'll end poll and share results. All right, sweet. So the majority of us have gone for E as an option, but there's a few in there for B, C, and D. So that's absolutely fine. Okay, cool. So the answer to this is, well, first of all, can I just ask people to put in the chat what they think is going on in this particular patient, if you're feeling brave? Or even if you're not, just go for it and guess. It's absolutely fine. Yep, myocarditis, rheumatic heart disease. Cool, rheumatic fever, endocarditis. Yeah, group B strep, yeah. Cool. Well, thank you very much, those guys, for answering. So this is rheumatic fever, which is secondary to Group B strep, as people have mentioned. And the answer to this patient, for this particular patient, is IV benzyl penicillin. Let's go through what's going on here. So, 13-year-old Bangladeshi girl. As soon as they give you a demographic from a third world country or a developing country, then they probably going to be something that's meant to hint that this patient, for some reason, is not going to necessarily have the same level of, they may not have had the same level of vaccination or hygiene in the past as we're quite, used to within the UK or within Europe. So this is just a sort of thing that they may when you come up with exam questions. Sore throat 3 weeks ago. So whenever I see that, I'm like, strep throat. I'm now complaining of joint pain. Okay, arms and legs. Widespread rash on her skin. So this is erythema. Make sure I get this one right. I think it's erythema marginatum. And there were strange rhythmic movements as you approach the bed. So this is meant to be something called Sydenham's chorea. All right. She's currently pyrexical. She's got temperature and her ECG show a first-degree heart block with no known drug allergies. So as people correctly said, the thing that's going on here is this patient's had a Group B strep infection or strep pyogenes infection, against which the body's developed a hypersensitivity or autoimmune reaction, which is leading to all of these problems happening here. The first thing we want to do is trying to make sure we get rid of all of that nasty bug. And Streptococcus is particularly susceptible to benzyl penicillin, which is why E is our first option. So chlorphenamine, that's an antihistamine. So if we were thinking that this was an urticaria or rash caused by, allergy or an anaphylactic reaction or an allergic reaction, then that's maybe what we're thinking of. But given the other history, we're probably not thinking that this is this. Erythromycin could be given if the patient's penicillin allergic. Flucloxacillin is standardly for staphylococcal infections, and oral doxycycline could be used for strep throat. But obviously, this patient is pretty sick, bless her. So we're going to be going for the IV bad boys in this one. All right. So let's talk about rheumatic fever. So as we discussed, Group B strep or strep pyogenes infection leading to a type 2 hypersensitivity reaction. Now, what does that mean, Rohan? It's probably a question that some of you might be asking. Some of you probably already know the answer, in which case, good for you. Fantastic. What that means is that you have this bug that's coming along, and the bug has got proteins on it. And as you probably remember, the body tries to deal with this bug by targeting the proteins which are on the bug, and therefore recognizing it and eating it and getting rid of the bug. Now, the issue with strep pyogenes is that the proteins which are on this particular bug are very similar to certain proteins that are found on the cell wall of our cells. So as soon as the body develops antibodies against this particular bug, it also is developing antibodies against different parts of the body as well, and therefore it's attacking that part of the body, leading to an autoimmune reaction, which is obviously a problem. The diagnosis and investigation. So the investigations that you would use is in order to make a diagnosis, obviously. And the diagnostic criteria that we use is something called the Jones criteria. So the Jones criteria, in order to make a diagnosis of rheumatic fever, you need to have evidence of a streptococcal infection from either from antibodies, a throat swab, or a rapid group A strep antigen test. Group A strep. For this one, not Group B, and Jones criteria, of which you either need 2 major or 1 major and 2 minor. This can be remembered by helpful mnemonics. So you've got the major criteria with Jones and minor criteria with fail. So major criteria, so J for joints. So if you've got swollen and painful joints and arthritis, that's a major area. Obviously, the pancarditis picture, so a pericardial rub would be something indicative of that. These nodules, the rheumatoid nodules that you're getting, is also going to be a major criteria. Erythema marginatum, as we described, and Sydenham's chorea that we described as well. For the minor criteria, you've got a fever, arthralgia, so painful joints, not necessarily swollen, falling into the criteria of arthritis, inflammatory markers raised, and a lengthened PR interval. As long as we don't have pancarditis as being the major criteria. Just so that we understand, if we're saying that this patient's got arthritis, we can't then use a minor criteria of arthralgia. And similarly, if we've said the patient's got pancarditis, we cannot use the lengthened PR interval as being a minor criteria. You need to have another one of the minor criteria if that's what you're looking for. Okay. In terms of the management, antibiotic, starting off with IV benpen and then moving on to phenoxymethyl penicillin, and analgesia like NSAIDs, such as aspirin is quite commonly used. And then also, if you've got something like Sydenham's chorea, then you may need to use some benzodiazepines like diazepam as well, in order to be able to help with those problems. Usually it's quite a involved diagnosis and treatment. Which NSAID for children under 6? Honestly, not got a clue. I don't know the answer to that particular question. I would be very surprised if they asked you it as well. If I was faced with that particular scenario, I would definitely be asking up the chain as to exactly what they want me to do in this particular patient. Because as you very rightly said, giving aspirin, for example, in a kid who's under 6 could lead to Ray's syndrome, which is exactly why you've asked that question, which is very good knowledge. But I don't know the answer off the top of my head. I'm really sorry. Nisarg, if you've got a way to be able to find out that'd be really useful. But obviously we'll go from there. Sorry, Isu. Any other questions? You're welcome. Cool. Anyway, next question now. 47-year-old IV drug user comes into A&E with a 7-day history of a fever and fatigue. On auscultation of his chest, you notice he has a pan-systolic murmur, which has not been documented before. He has had no previous surgical history. His observations are as follow. BP, which is a bit low, heart rate, which is 112, temperature 38.2, a respiratory rate of 23, and oxygen saturations of 97% of room air. Given the most likely diagnosis, in which location is the murmur likely to be the loudest? A, I'm not going to read them out. A, B, C, D, or E. I'm not being rude. I'm going to try and look up in the BNF for Isu's question earlier.
That's exactly what I'm going to do. That's exactly what I'm trying to do right now.
Oh, fine. Nisarg, if you're on that, then that's fantastic, and I'll continue on with my talk. So I'm going to end the poll there. So, and share the results. Fantastic. Okay, cool. So it's actually a fairly even spread, which generally means that none of us have any idea what's going on with this particular scenario, which is absolutely fine, and the reason you've probably turned up to this lecture. All right. So the answer in this question, okay, let's go through it. First of all, we've got a 47-year-old IV drug user coming in with a 7-day history of a fever and fatigue. Okay, he's got a pan-systolic murmur, which has not been documented before, no surgical history, and is everyone in agreement, if you just put in the chat, that this patient doesn't look great at the moment? He's got a blood pressure, which is a bit low, a heart rate that is a bit high, a temperature, which is a bit high, and the respiratory rate, which is bordering on a little bit high, but is maintaining his oxygen saturations. Everyone in agreement that he doesn't look great? Sweet. Okay, cool. Can we put in what we think the diagnosis might be in this patient? Don't worry if you just put it in. Don't worry about endocarditis. Okay, yeah. I see one. Just what we're thinking. If you don't know, put don't know. Absolutely fine. i.e. infective endocarditis. Sweet. Sweet. Right. I agree. This patient's got infective endocarditis, yeah? Now, the key thing in here is that this patient's an IV drug user. So the most likely thing that's happened is that this patient has been injecting. Again, we have to be quite, especially with SBA questions, you notice that they stereotype quite a bit. And the stereotype is that they're going to be injecting. They're not going to necessarily be cleaning everything as they go through. So they're going to be injecting things through the skin. And when it goes through the skin, it's going to be going to the venous roots, obviously. It's going to be feeding into the inferior vena cava, and then going into the right atrium. Any bugs that are going through, obviously, are going from the going through the skin into your venous system, into the inferior vena cava, and then into the right atrium. And then the first valve that they hit is going to be the tricuspid valve, which is, I believe, fourth intercostal, which the tricuspid site is the fourth intercostal space, left sternal edge, which is why that is the correct answer. The usual most common sites in a patient who hasn't got any other risk factors is the mitral area. But in this particular patient, because of the IVDU use, it's going to be the tricuspid. Everyone happy with why that's the case and the mechanism behind it? If you could just put a little bit of a yes, then we can move on quickly and it's not awkward. Yes, thank you. Straight away. Fantastic, good stuff. Yeah, sweet. So then the other area, second intercostal space, right sternal edge, is going to be the aortic area. Oh yeah, sure, no worries. So let's go back. So we've got an IV drug user, and the stereotype is that this patient may not be using their injections or their needles very safely, should we say. So you imagine that there's, you've got a bunch of skin commensals on your skin. You're going to be injecting your drugs. Well, hopefully not, but these people, unfortunately, would be injecting their drugs. It's going through the venous system. Then it's going to go back into the inferior vena cava. It's going to go to the right atrium. And then the first valve that blood is going to hit is going to be the tricuspid valve, and the space associated with the tricuspid area, when you're listening, is the fourth intercostal space, left sternal edge, which is why the tricuspid area is, that's why you would hear the murmur, because the organisms have gone through the blood, gone to the first valve that it's hit, which is the tricuspid valve, and then seeded in that area and caused the endocarditis of that particular area. Does that make sense, Merose? Okay, you're absolutely fine. Thank you very much for asking the question. I'm sure that you weren't the only one who was struggling. So that's absolutely fine. I'm very happy to do all of that stuff, yeah? Cool. A 58-year-old gentleman comes into A&E with a 7-day history of a fever and fatigue. An auscultation of his chest, he's got a pansystolic murmur despite a normal echo 3 weeks ago. He's had a valve replacement surgery. Isn't the tricuspid area on the right sternal edge? No, it's just there, left sternal edge. The right sternal edge, you've got the aortic area, that's on your right side, so the patient's right. Then you've got the pulmonary area, second intercostal space, left sternal edge, fourth intercostal space, left sternal edge is tricuspid, and mid-clavicular, fifth intercostal space is mitral. Cool. I'm hoping that's okay, Isu. I'm going to continue on with my explanation. Ah! Oh, okay. No, absolutely fine. It's easy to get confused. All good. 58-year-old gentleman comes into A&E with a 7-day history of a fever and fatigue. On auscultation of his chest, he has a pansystolic murmur despite a normal echo 3 weeks ago. He's had valve replacement surgery for a tricuspid valve 4 months ago. Observations are as follows. BP 97/56, heart rate of 114, temperature of 38.4, respiratory rate of 22, and an oxygen of 95%. Given the most likely diagnosis, which is the most likely organism? Staph epidermidis, Staph aureus, Strep pyogenes, Strep viridans, or Strep bovis? Sweet, thanks so much, Nisarg.
By the way, I don't know if it's my BNF app or not, but every time I click on something, it just comes with a blank page. So I'm not sure if the BNF app is down or not, but I can't get access to it.
Okay.
Also, if you guys want a mnemonic for the auscultations, a nice one I learned was all physicians take money.
Yeah, works.
Yeah.
I'm just taking a look. It's been about a minute. In terms of that previous question as well, I think it was Isu. I'm not sure. They seem to be happy enough in kids generally. I don't know about specific in rheumatic fever, but generally they seem to be happy with naproxen as a potential option as well. So in terms of NSAIDs, the main one you're worried about is aspirin, which is what I remember as well. But the other NSAIDs, I think you can get away with in kids. Right. So let's end the poll right there. Good response rate, by the way. Good job, everybody. And again, it's a fairly spread out thing. None of us want to go for bovis, which is a bit sad, but is what it is. And again, it's a bit spread out, which indicates that we're not 100% sure of what's going on. Sorry, I've just shared the poll now, which is again absolutely fine. The whole reason you've come here. So hopefully we're happy that this history is fairly similar to the previous guy. Guy's got a fairly unspecific fever fatigue history, and he's got a new murmur. New murmur and fever is infective endocarditis until proven otherwise. He's had valve replacement surgery for his tricuspid valve 4 months ago. Now, the relevance of that is that if a patient's got an indwelling lining, or if they've had valve replacement surgery, for example, then usually within 2 months of that surgery happening, the most likely organism to infect, if they get infective endocarditis after, the most likely organism to cause that is going to be Staph epidermidis. However, after that 2-month period has passed, it then goes back to the usual flora of being most likely. And in that case, it's Staph aureus, which is why B is the correct answer. Okay, so as I mentioned, Staph epidermidis would be most common for prosthetic valves within 2 months of surgery. We're outside that window, so we're chilling. Staph aureus is generally the most common cause of infective endocarditis. Strep pyogenes is the one that was associated with rheumatic fever. Strep viridans used to be the most common one, but now it's gone back to Staph aureus. It's associated with dental work as well. And Strep bovis, that's interesting. It's got an association with colorectal cancer. So if you see a question, which is, this patient has been diagnosed with infective endocarditis, the blood cultures have grown Strep bovis, what is the next most appropriate investigation? The answer is, after you stabilize the patient, the answer is actually a colonoscopy. And the reason why is because Strep bovis is a gut flora commensal, basically. And in a patient who's got colorectal cancer, what's happening is that there's invasion of that. There's an invasion or breaking down of that barrier between the gut flora and then your bloodstream. So gut flora is now getting into your bloodstream. And one of the biggest ones in there is going to be Strep bovis. So basically, Strep bovis makes its way into the bloodstream, then it goes over to the heart and causes infective endocarditis to happen. And the reason why that's going is because of that colorectal cancer being there in the first place anyway. So the point being is that if you're faced with that question, the patient's growing Strep bovis, you just look for colonoscopy in the answers and you just click that and you know that's fine. All right. Unless there's anything else, just, screw you over. But that's how I used to do it. So yeah, that's it. Cool. So that's infective endocarditis. This is now infective endocarditis. So what does it mean? It's an infection of the valvular leaflets, starting off most commonly in mitral valve and then aortic valve, and then a combination of the two, and then tricuspid, unless it's an IVDU, and then the pulmonary valve. All right. The causative organisms, so Staph aureus is the most common, then followed by Strep viridans. If they've got a line which is in situ or have been there in the last 2 months, or they've got a prosthetic valve, then Staph epidermidis would be the causative organism we'd be worried about. And Strep bovis, as we talked about in colorectal cancer. There's a bunch of organisms called the Hackeka organisms, and as well as Coxiella, which can also cause can also cause infective endocarditis. The clinical features generally, when they present, they're quite unspecific. It's this lethargy, fever, but they start under heart failure. So sometimes they can go in and people may think they've had a chest infection and heart failure, and actually what's happened is they've got infective endocarditis. But the important thing to remember is that if you've got a fever and a new murmur, that's infective endocarditis until it's proven otherwise. All right. Some of the clinical features you can get are these Jain lesions and splinter hemorrhages. The reason why those come up, the reason why those happen is because you've got the effectively this colony of bugs living on the valves of the patient, and sometimes these little bug colonies can fly off and cause emboli in the palms or in all parts of your body really, but specifically when it's in the hands and the palms. The painless ones are Janeway lesions and the splinter hemorrhages in the fingernails. If you've got an immune complex, i.e. you've got a some IgG antibody or whatever it may be along with a bit of bug, then these can these can be quite painful when they hit the peripheral system and can present as what's called Osler's nodes. And the way that I used to remember Janeway's lesions and Osler's nodes, which one's which. Osler's nodes, I remembered something like somebody told me, ow, Osler. And for some reason that stuck, and that's something that worked for me. So if it works for you, fantastic. If it doesn't, that's absolutely fine as well. So there is also a diagnostic criteria for infective endocarditis. That's called the Duke's criteria. Again, there's some major and minor stuff involved. So in order to make a diagnosis, you either need 2 major, or 1 major and 3 minor, or 5 minor criteria. And the mnemonic is B liver. So major criteria is one of blood cultures and echo. So the blood culture is actually showing organisms present. We need either 2 for a typical organism or 1 for a positive Coxiella. Usually in clinical practice, we're asked to take 3 blood cultures, all from separate sites. They also think about an echo showing vegetation is indicative of a colonization of that particular valve. Again, this makes sense, right? Because it's an infection of the endocardium, usually valves. So it makes sense that these two, the infection markers and the, is it on a valve, are the 2 major criteria here. And liver is lab stuff. So blood culture is not meeting the major criteria. Immunological findings like Osler's nose or nephritis, vasculitic findings like emboli, Jain lesions. Are they extremely hot with a fever above 38? And do they have risk factors like a previous cardiac surgery, or are they an IBDU, for example? So that's infective endocarditis in a slide, effectively, with some hopefully useful mnemonics. Any questions on that? Ooh. Oh, IVDU means intravenous drug user. Sorry about that. It's me using abbreviations without saying anything, without explaining them, which is a bit wrong of me. Happy with that, Casey? No worries at all. Any other questions? Can you explain Hackek organisms? So Hackek is actually, I don't remember each individual one. I think Haemophilus is one, and I can't remember the other ones, to be honest. So they're just, the Hackek is H-A-C-E-K. I think Klebsiella is another one. And effectively, each one of those letters is another, effectively, I think genus, effectively, of bacteria that could potentially cause infective endocarditis. They're just something that seems to come up when it goes to this particular diagnosis. I didn't remember every single one of those things, and I was fine. So then that's why I've just put it in there as a sort of letting you know that is. If you want to go in and learn a little bit more about them, go ahead, absolutely do so. Oh, so fantastic. Kingella, oh, it was close. But yeah, so that's just a bunch of different organisms that can potentially cause these infections. I just didn't want to mess up the slide and make it, put them all in there basically. But I didn't remember them, if that makes any difference to you guys. So all good. Any further questions, guys? Cool, let's roll. So this has been taken from the BNF, and this is just the antibiotic therapies that you can use to be able to manage infective endocarditis. This wouldn't be my first thing that I would necessarily go in and learn, but if you've got, you don't know what an MI is, for example, probably you don't need to know this stuff. But if you want to just build up a little bit more knowledge, this is what this is for. So there's a few things that generally are coming up as themes. So initial treatment for a native valve is amoxicillin plus or minus gentamicin, depending on how serious the infection is. If they're septic, you go vancomycin and meropenem, so the real big boys. If they're pen allergic, you go vanc and gent. And if they've got a prostatic valve, you go vanc, gent, and add in some rifampicin as well. If they've got staphylococcal infection, then, and it's a native valve, you just go for Fluclox. But if it's a prosthetic valve, there's a bit more uncertainty exactly how that valve's going to respond, and it's they're going to see it a little bit better. So you need to hit it with some bigger drugs like rifampicin and gentamicin. As you mentioned, Streptococcus is particularly sensitive to benzoyl penicillins. If they're not fully sensitive, you could add on some gentamicin. If there are any of the Hackek organisms, then you might go for Amox and gent. And then if they're resistant, then you go for Kef and gent as well. Obviously, the answer to any antibiotic therapy when you're asking an OSCE is that I would check with my local guidelines and prescribe accordingly, responding to sensitivities from various cultures that we've gotten. But that's just something from the BNF that I just thought I'd put in there as in case you wanted it for completeness. You may need to consider surgery, and in situations where you do so is either when the valve has become completely incompetent, or if actually for antibiotic benefit you need to remove and replace the valve. So if they've got cardiac failure, for example, or if there is an aortic abscess, which is there, the infection isn't responding to the antibiotics that you're giving, or there's still emboli after the antibiotics have been given, then that would be indications then for replacement of that valve. after an infective endocarditis situation. Okay. So, sorry, is there any other questions about IE? Are we happy enough with that? Okay. Oh, hello. Very happy. Ah, that's very nice of you. Cool. SBA 8. 24-year-old man's come into A&E's, passed out in the middle of playing football. Fourth time this has happened, on an auscultation, you hear an ejection systolic murmur loudest in the left lower sternal border. His mother comes in and tells you that this patient's father died age 32 following a similar presentation. Given the most likely diagnosis, which investigation findings would be most likely? An echo showing mitral regurgitation and asymmetric hypertrophy, an ECG showing right ventricular hypertrophy, an FBC showing HB of 76, an ECG showing ST elevation, or an echo showing aortic regurgitation and symmetrical hypertrophy. Do we have a poll in this? Sorry, I know how to set that up. Oh,
yeah, sorry, my bad.
I'm going to go let it run for a minute. Oh, can we get to 50%? Oh, no. Okay, that's fine. Well done for all those who voted. And these are the answers. So majority of us have gone for A, and then there's a few spread between the other options as well. Okay, so 24-year-old guy, young, that's the first thing I think is young. He's come to A&E because he's passed out in the middle of playing football. Now, can people put what they think the diagnosis is in the chat? Okay, some people have said HOCM. So other people have said some HOCM as well. Okay, cool. Yeah, I agree. This is hypertrophic obstructive cardiomyopathy. So or HOCM. So well done for those guys who are thinking about that. So immediately to see that, I think HOCM, that's the immediate first thing I think about. Otherwise, well, playing football suddenly collapses, bang, that's what I'm thinking about. Or has been hit in the head and it may be a middle meningeal artery lesion. He's had lucid interval or something like that. But you know, that's after he's been hit in the head with the football. But in this case, absolutely, HOCM is my first line, my thinking. Ejection systolic murmur, yes, this fits. And his mother comes in and tells you the patient's father died at age 32 following a similar presentation. Now, we're going to discuss the same in the later slide, but just to let you know, HOCM has got an autosomal dominant inheritance. So if you've got a family history and you've got the sort of presentation, you almost got your diagnosis, all right. It's associated with, on echo, with asymmetric hypertrophy and mitral regurgitation, and therefore those who voted A were absolutely correct. This is predominantly left-sided, so you have the left ventricular hypertrophy in HOCM as opposed to right ventricular hypertrophy, which is why B is incorrect. C, so he could be anemic, that's true, like that's can cause murmurs and can cause the fainting episodes, but it's really, you know, he doesn't have any particular reason to be anemic. And also we've got this family history that's pointing us into this direction of HOCM. ST elevation on ECG. So it's true we have ischemic changes on ECG associated with HOCM. They tend to be T-wave inversion predominantly, though not ST elevation. And we don't think this patient's had a STEMI, which is the other thing that we could be thinking about. And aortic regurgitation and symmetrical hypertrophy. So usually it's MR and asymmetrical hypertrophy with the echo findings. So let's go over HOCM. Epidemiology, 1 in 500, autosomal dominant inheritance, as we talked about before. What's going wrong in this condition is you've got a defect in the genes coding for some contractile proteins, and that leads to hypertrophy of the left side of the left septum, of the interventricular septum predominantly on the left side. Exactly why it's on the left side, I'm not 100% sure, but this is the pathophysiology behind HOCM. What happens then is that you've got, as you can imagine, when this side of the heart contracts, you've got an obstruction, which is preventing proper blood flow through this side of the heart, and that leads to your murmur. And because you're needing to push a little bit harder, and as muscles get worked harder, they get bigger. That's why you get the left ventricular hypertrophy occurring secondary to that as well. This, because you're getting this left ventricle getting bigger and bigger, this mitral valve leaflets are getting further and further apart and becoming more regurgitative. And you've got this particular thing called systolic anterior movement of the anterior leaflet of the mitral valve, which is just a sort of SBAE sort of thing that you may want to parrot off to one of the cardiologists or something to look smart. And also because of the hypertrophy that's occurring, you can have a disruption of the electric mechanisms the heart as well, leading to arrhythmias and some cardiac deaths. In terms of the presentation, it can, as with hypertension, be asymptomatic, but obviously can lead to these collapse episodes, the ejection systolic murmur, loud run Valsalva maneuver, and also the sudden cardiac death. And if people remember the Fabrice Muamba case, the guy who passed out in the middle of a football pitch a few years ago, this was the reason why. It's because of HOCM. And you guys might know a little bit better, but I'm pretty sure now that when it comes to professional athletes, they usually do a lot of screening to make sure that they don't have these underlying conditions as well. I don't know if anyone else knows a bit more about that, but this is something that I remember hearing, but I can't independently verify that. But it would make complete sense if that was the case. Okay. Any other questions about that? Cool. I just wanted to show you this ECG. So this is the ECG from a patient who's got HOCM. And the thing that I wanted to point out to you guys is this left ventricular hypertrophy and the T-wave inversion, which is going on here. Yes, but it happened 4 times. It's common for that to be that recurrent. I think the idea I was trying to go with here is that he's had these episodes beforehand, which is just getting worse and worse. Haven't actually had a case of mine. I've not actually seen a case present as such, but it wouldn't surprise me if they'd had these episodes that, actually thinking back, he'd had these funny things happen before, and I'm not quite certain about it. They've gotten a bit better and they've moved on. So the answer is I'm not 100% sure because I've not seen it in clinical practice. The main thing I would remember from your guys' perspective is that if you've got a young person with a sudden collapse, definitely think about this as being a differential. I wouldn't worry necessarily if it's happened before or if it's, the first presentation, because it could be either or, to be honest. Is that okay? Does that answer that question, Casey? Sweet. So I just want to, hello, another question. Yeah, no worries, sweet. So so first of all, T-wave inversion, I think, is fairly obvious here. You've got your P waves, your QRS complexes, which are just coming one on top of each other, and your T waves, and obviously this is going down, right? The other thing as well is that can we appreciate, now if we go back to our ECGs first of all, so an ECG is basically a measure of the electrical activity of the heart, right? Now, if we remember our chest leads, so we've got effectively V1, 2, 3, 4, 5, 6 running across here. V1 is going to be predominantly looking at the right side of the heart. V6 is going to be predominantly looking at the left side of the heart. And just to reiterate the stuff that I'm sure you've been told before, is that when you see electrical activity going upwards, it means that electricity is going towards that particular lead or that particular lead. When it's going away, it means it's going further away from that particular lead. In this case, the V1, which is the right side, and V2 as well, which is predominantly the right side of things, the QRS complex is predominantly going away, whereas in V5 and V6, it's predominantly going towards. So this points to the left side of the heart having that big muscle mass on that side, because that's predominantly all left-sided. And you've got these deep, S waves here, and these really tall R waves, and there's certain electric criteria which can make a diagnosis of electric hypertrophy based upon this. And this is something that you may see, for example, in a patient who's got HOCM. Are people relatively happy with that explanation of ECGs and the reason why this is a HOCM-related ECG? Or any further questions based upon that? Any other changes? In this particular condition, no. We can have arrhythmias occur secondary to it. So I think the actual common reason why the people actually have the death occurring is because you've got such bad conductance, they end up going into VTAC and VF. Just because the conduction is so messed up. But obviously in this case, those are the main changes that I would see in this particular ECG. Cool. Any other questions? Cool. I'm going to assume that that's a resounding no. So in terms of the HOCM investigations and management, ECG showing some particular signs, they can have AF and they can have deep Q waves as well associated with obviously abnormal conduction pathways occurring within the heart. There's echo findings that can be remembered through this mnemonic, Mr. Sam Ash, mitral regurgitation, systolic anterior motion of the anterior septal leaflet, and asymmetrical septal hypertrophy. And the main way that we manage it is to try and stop the arrhythmias occurring. So amiodarone and beta blockers, both some relief, and then we can consider pacing or implanting a defibrillator as well to be able to restart the heart in the case that it does go into a pretty horrible arrhythmia. Okay, and at the same time, if this patient's developing any other symptoms like heart failure sort of pictures, then we might need to be able to manage that accordingly as well. That is my final.